so our navigation program here at Dana-Farber is trying to address some of these challenges. And I know the concept of a navigator is different in different places. And I think that the way that Dana-Farber has approached this has been really amazing. And so as you think, Fabia and Ariana, about a patient who's in need, who comes to our center, whether it's breast cancer, whether it's gastrointestinal cancers, how do you approach your role as a navigator? How do you get involved in that patient's care? And what is it that you're doing for them and with them over their journey? We can start with Fabia if you want.
Yeah, so our focus in our program is to kind of catch new patients from certain neighborhoods in Boston that, there was a health needs assessment done that identified which zip codes kind of have lesser health outcomes when it comes to cancer. So those are the zip codes that we focus on. So as soon as a patient that lives in that geographical area is scheduled, we kind of jump right in right away and just introduce ourselves and kind of start with assessing, are you coming to your appointment alone? Do you have any questions? Do you know how you're getting there? Do you know where we're located? Kind of just building that relationship, because as Ludmilla said, we do have a lot of patients that, might not trust the medical system as much. And it's also a very just vulnerable time in general, just being diagnosed with cancer. So kind of just establishing that relationship of being their point of contact so that they feel comfortable and know that they have someone to go to if they need anything. And then we meet them for their first appointments if they would like, accompany them, if they're coming alone, and kind of take it from there. Like we said earlier, help with transportation if needed, direct them to community resources to help with financial things, food, all of that.
Is there something systematic that you do when you meet the patient as far as sort of assessing what those needs might be? Or is it more open-ended with the patient and just getting a sense from them of what's challenging them?
I will say that, after we build that relationship with the patient, our assessment is definitely ongoing. We recognize that patients are going through a lot and they might not want to open up to you, to someone that they just met, about all of these very difficult things. So it is kind of just, you attend their appointments, listen to what's going on, and just, until they're comfortable to kind of bring those issues to you, but we don't pry in or ask too much up front, at least.
That's great. And Ariana, what about your experiences and your patient approach and how you handle that in the breast program?
Yeah, so I think I echo a lot of the sentiments that Fabia was saying, but I think with my patients, I really try to relate to them that I'm here to be kind of like their confidant or like a liaison. Like like Fabia said, the point person that's going to get communication from you to your care team. Like anything that you need, I'm here so I can eliminate that barrier of you not having the ability or maybe even confidence to talk to your care team because they are new patients and their cancer diagnosis is still very fresh. So they still have to digest that. And like along with it being an ongoing assessment, I think it's just allowing people the space and time, because I think with a few of my patients, they're not quite comfortable yet, or maybe they feel like, talking to me will be like more on my plate. Like it's amazing how thoughtful like patients are, because they'll say, oh, like, don't worry about it. Like, I don't need any help. Like, I don't want to worry you. And I'm like, but I'm here for you. Like, I want to be your resource. And I think like that's kind of the angle I approach it from. Like, they're not a burden. I want them to come to me, like, no matter what the request is, just so they know that I can be a reliable point person for them.
That's great. And as a follow-up question, Ariana, how do you interface with the clinical team and communicate back, or are you sort of in the background, just sort of helping support that patient? What kinds of interactions do you have with the oncology care itself?
Yeah, so ahead of a patient's appointment, if I find out like during the intake, like when I first call the patient that they're coming alone and they would want someone to escort them, I'll email the doctor's ONN and I'll tell them that I'm accompanying the patient to the appointment. And then once the ONN passes it to the doctor, or sometimes I'll even vote message the doctor the day of and like, hey, like I'm here with the patient in the waiting room. So when we're in the appointment together, we're getting the information as it comes together. And I feel like that's super important because anything the patient like misses or doesn't quite understand, like I can explain it to them in a way that is more of like their vernacular or in a way that they can understand it a little better. And I think as the appointment ends, if the patient has any questions that didn't come up during the appointment, I will always send an email to the care team for the patient and say, oh, like the patient had this question. Is there anyone that can get back to the patient? So I'm kind of like in the background in the appointment because I'm listening and observing, but when it comes to after the appointment, I'm like sending emails and I'm following up with the patient, like, how do you feel? Is everything okay? Just to make sure that everything is covered.
Great. And for those of you out there, ONN is Oncology Nurse Navigator. In our program, it's more of a clinical role, a nurse who helps with symptom management and some of the care coordination as well. So very integral part of our team as well. So Ludmilla, turning to you, you've all talked about this element of trust and how important that is in establishing a rapport with the patient and really getting them comfortable with the idea of cancer care and cancer care in a new place. And I think that's really clearly a sort of priority when you're meeting a new patient. And Ludmilla, I know sort of in the past you've worked on lots of ways of making that patient comfortable that don't only include patients who walk in the door at Dana-Farber, but trying to capture them earlier than that, perhaps in their own community setting or their own community health center. Do you mind talking a little bit about the work that you've done in our Boston community around that?
Sure, thank you so much. So yes, we've been in historically marginalized communities, partnering really closely with our federally qualified health center partners, our PCPs, for, gosh, 12 years now. And, it's been such an eye-opening experience that it's really important to have longitudinal relationships. And a lot of our primary care colleagues have been really amazed that we've come and we've stayed. Week in, week out, we go with a clinical team and help sort of rule in or rule out cancer. That's how I see our diagnostic clinics. And whether it's with the patients or with the providers in our community settings, we approach the care with the utmost humility. And we've had incredible feedback, but it's taken time, right? Relationships take time. And a lot of providers have said to me that, academic medical centers are very extractive, come into a community, take the data, take whatever, and then leave. But to have this relationship between specialty care and community care is so it's such a rich relationship. It's bi-directional. We learn, the patients bring incredible joy and wisdom, and then we build trust. And we know that if we meet a patient in the community first, and then navigate them to Dana-Farber, and they end up on a offered a clinical trial, they're much higher, and this is proven by our data that they're much more likely to participate in a clinical trial because we've built that trust. So it's something we need to realize that I think as providers in general, that relationships with our communities are essential to good outcomes and trust.
And I think it's a really unique model, the way that your program has been able to really enter the community health centers and not only develop trust with the patients, but with the medical community there and the clinicians there, knowing that if they have a concern, that you're right there, the team of Dana-Farber is right there to help evaluate and get them what they need. And I think that makes it, you want to make it easy. And I think that's been a really special part of your program. And so I could talk to you all day about these issues. They're so important and there's so much to say and so much to do. But as we think about sort of closing up, I wanted to turn to each of you to sort of think about if you could have anything forget money, forget limits, right? If you could have anything that you wanted to serve our patients with cancer as best as we can, is there something that stands out to you as the thing that we need? And I know this is a hard question because there's so much that you could do. But if there's sort of one thing you could have with unlimited money and no limits, what might that be? Who wants to go first? Not to put you on the spot, maybe Fabia. What do you think?
Yeah, I think about this often actually, and jokingly amongst the team, we always say a hotel and a van would probably be the best things that we could get. But I mean, it's a joke, but also not really, you know. I think just prioritizing our patients, making sure they have a safe place to stay while they're receiving treatment, and reliable ways to get to their appointments, because those are really the main things that, you know, end up preventing people from coming in and not following through with their treatment. So I'll stick with that answer.
That's great. How about you, Ariana? What do you think?
I mean, yeah, it is a really hard question because there's so many barriers, but I think for patients that they don't, when they come to Dana-Farber, they don't have a clinic that is actually associated with Mass General Brigham. I think like a streamlined system of like getting their records, like if there was some way that we could have it be as fluid as, you know, when a person comes from Brigham or when a person comes from Southern Jamaica Plain, like I think that would be amazing because a few of my patients are coming from BMC or Harvard, and it's just taking
just to, you know, our audience is beyond Boston, so we want to.
So I think, you know, if there was like an integrated system to make the transition from like outside our network a little bit more fluid, I think that would be great because a lot of our patients, you know, they want to get timely cancer care and they deserve to get that. So that would be mine.
That's great. Really important. And Ludmilla, what do you think?
Oh gosh, so no money limits. So besides the hotel and the van and, you know, streamlined sharing of information, I really think every patient, you know, if every patient who comes in our door can have a patient navigator who accompanies them, who, you know, I see our patient navigators as conductors, right? Sort of like behind the scenes, making sure that nothing, no note is missed, right? That everything is just absolutely flawlessly sort of, you know, across the fragmented system and the different departments, you know, just streamlined. So I think every patient, if I could have an army of patient navigators, I would be a happy woman.
I love it. And I would just add that all the things you all raised are so important and are very doable in our world. And I think that these are tangible things that we can all work towards bit by bit in our centers, in our communities. And I think they're very achievable.